The important factors for pathogenesis of macular edema in RVO are, besides venous stasis, it is upregulation of VEGF and the release of inflammatory mediators like interleukins, TNF-alpha, and prostaglandins. In diabetic macular edema, besides hyperglycemia causing blood-retinal barrier dysfunction, inflammation is caused by cytokines and chemokines, and also there is VEGF upregulation due to capillary non-perfusion and microvascular damage. The main purpose of this study was to compare the changes in visual acuity and macular thickness in eyes with macular edema secondary to BRVO, CRVO, and DME in eyes which had been treated with combined therapy of 0.05 ml of bevacizumab with either 0.7 mg of dexamethasone implant or posterior subtenon triamcinolone acetonide. This was a retrospective non-randomized study of 50 eyes of 50 patients with macular edema and with a central macular thickness of more than 250 microns, which was caused by either BRVO, CRVO, or DME, eyes with traction RD, epiretinal membrane, NVD or NVE were not included in the study. 23 eyes had BRVO, 12 eyes had DME, and 12 eyes had CRVO, and 17 eyes had DME. 30 eyes were treated with dexamethasone, and 20 eyes were treated with triamcinolone. In all the patients, initially intravitreal bevacizumab was given, and then within 15 days, either dexamethasone implant or posterior subtenon's triamcinolone was given. And if we saw that there was a recurrence of macular edema at the time of follow-up, then intravitreal bevacizumab was repeated. And this primary endpoint was the change in vision and central macular thickness. So here you can see that this is a heat map of the changes in vision in the dexamethasone group. DME in dexamethasone implant was able to maintain the most stable improvement of vision. Both CRVO and BRVO, the improvement of vision was there till about 60 days, but at 90 days follow-up, there was a slight decrease in vision. Many of these patients we had to repeat the bevacizumab after the 90-day follow-up. In the triamcinolone group, BRVO did much better. They were able to maintain the visual acuity more stably till 180 days. CRVO and DME maintained some improvement of vision up to 60 days, but after 60 days, there was a decrease of vision in both the groups. This is a heat map of changes in macular thickness. Here you can see in the dexamethasone group, here you can see that BRVO and CRVO were able to maintain a decrease in macular thickness up to 60 days. At the 90 days follow-up, the macular thickness had increased, and then a repeat of anti-VEGF was done in some of these patients, and there was this reduction. However, in dexamethasone overall, DME patients did not have a very good change in macular thickness. In the triamcinolone group, however, you see that all the three groups were able to maintain a decrease in macular thickness right up to the 180-day follow-up. So compared to dexamethasone, triamcinolone had a much seemed to have a slightly longer effect. Corticosteroids are known to act by blocking glucostasis, by restoring the integrity of the tight junctions, by blocking inflammatory mediators, and by reducing the swelling in the Muller cells. Other studies have shown that the OMA study has in refractive RVO has shown that both dexamethasone and triamcinolone both don't have much improvement of vision but have a significant improvement of macular thickness. Other studies done in refractive DME have shown that both triamcinolone and dexamethasone are able to reduce the macular edema. IOP increase was seen to be significant in the triamcinolone group. Between the dexamethasone and subtenon's group, there was no significant difference in outcome. However, macular edema decreased significantly in both groups. Triamcinolone seemed to have a longer effect. There was not much change of vision because of the disruption of the inner retinal layers. And most of the studies done so far have been done on this thing old macular edema, which is not responding. So actually, larger studies should be done to find the this thing benefit of early steroid treatment. Thank you.
So what was your conclusion? Combining a steroid with anti-VEGF?
Yeah, no. So so this was early, so that it does have an effect, but this is just a 6-month follow-up. Okay. So actually maybe a 2-year follow-up will actually show whether early steroids are beneficial, or you should only treat only if it is non-responding.
So now what about the combination therapy?
The combination only. So this combination, so whether this thing combination in most studies started only if they were not responding to anti-VEGF, then you give anti-VEGF plus steroid. In this, I was giving it in the initial time, not waiting for it to become non-refractory.
So it was within 15 days?
I mean, some were 7 days, some were, it was a retrospective study, so some were within 7 days, some were within 10 days, things like that, but less than 15 days.
The previous studies has said that there is improvement in the macular thickness, but there is no significant improvement
because
in
of that drill,
visual
basically that, because of the factor of drill which is there in macular, that disruption of the inner retinal.
These were all naive cases?
Naive, because it's saying retrospective analysis. I mean, I've taken only from the first treatment onwards.
So the first, the moment
bevacizumab was given,
walks into a clinic, receives an anti-VEGF, which is like bevacizumab, and the patient is told that after 15 days...
so actually that is completely economic. Those who can afford Dexa, take Dexa. Those who can't afford Dexa, take triamcinolone.
Yeah, but all of them get an anti-VEGF in the
initially everyone's treated with one anti-VEGF. That's why this thing bevacizumab I've taken, because some were this thing Eylea with Dexa. So I mean aflibercept with Dexa. So those will that become complicated because is Eylea acting better or bit.
And what made you inject the anti-VEGF a second time?
If there was a significant increase in the macular edema at 90 days, because in some patients the dexamethasone implant in some patients wears out at about 3-month follow-up. So then if there's quite a lot of increase, then I used to just give one more injection of bevacizumab.
Was there any difference in the intraocular pressure?
Significant. The Dexa group, the IOP increased after 30 days, because after that they were all put on this thing, IOP lowering medication. So after that, because you can't keep the IOP high. So the thing is, at 30 days, the mean IOP increase in Dexa was 0.3, and in this thing triamcinolone it was 4.25. It was significant change.